Hello, my name is Dr. Robert Kaufmann, and we're about to go beyond the terminus. One of the most difficult situations we face when dealing with endo retreatment cases is to decide how much of the case to retreat. For many years, the general consensus had been that because the endodontist takes responsibility for the entire case once it's been referred for retreatment, it's incumbent upon the endodontist to retreat the case as a whole. That way, the endodontist does not have to rely upon the previous clinician's treatment for possible success of the case or complete resolution of symptoms. The canals have been completely recleaned and reshaped by the endodontist, and they can be sure that complete retreatment has been performed to the best of the clinician's ability. However, with greater emphasis now being placed on dentin preservation, this philosophy has changed. Gray areas occur when fixed prosthetics or post and core crowns are involved, and disassembly of the tooth frequently involves remake of the restoration. By the time we place endodontic retreatment fees together with the fee for the new post and core and crown, we're frequently close to the cost of extraction or implant replacement of one tooth like a molar, not to mention the inevitable loss of dentin that may occur through disassembly and endodontic retreatment. So there's a definite financial incentive to deal only with what we suspect is the symptomatic canal or roots. This has both advantages and disadvantages. Obviously, the advantage to the patient is that the cost will be much less because the entire canal system is not being retreated. And in many cases, disassembly is not required. The patient can maintain the existing restoration if it's in good condition, and with minimally invasive techniques, retreatment of the suspect canal or area can be performed with little loss of tooth structure and minimal loss to the integrity of the initial restoration. On the other hand, if the retreated tooth continues to be symptomatic, there's always going to be some question as to whether the other canals that were not treated may be contributing to the problem. Let's look at an example case. This is a 39-year-old male who came to see me as a result of symptoms associated with the mandibular left first molar. The patient had a history of pain in the tooth for more than 3 weeks. The pain was described as a 2 out of 10 and localized to the tooth and gum area. It was increased by chewing and biting and relieved by the use of non-steroidal anti-inflammatory medication. There was no swelling in the area, and the tooth hurt only when the patient bit on it. The referring dentist wished to restore the tooth and noted a periapical finding associated with the mesial root. CBCT imaging confirmed that the presence of a localized radiolucent finding was there associated with the mesial root, but the distal root looked normal periapically. The distal canals appeared to be filled short and possibly ledged. There was a post in one of the distal canals as well. So the question remains, how do we retreat this case? Do we remove the post from the distal canal and retreat all 4 of the canals? Or do we adjust their treatment so that we treat just the associated root that has the radiolucent finding? Is not treating the whole case below the standard of care when an apparently deficiently treated case has been referred for retreatment? It's a good question. I removed 2 thermophil carriers from the mesial canals. Also, there are medical legal issues that come with doing only half of the case and possible consequences should the case not heal or become symptomatic in the future. Other endodontists look at the same situation and have a different philosophy. Although these other canals may be less than optimally treated, they choose not to retreat them. They limit their retreatment to those canals that appear to have a problem. Removal of dentin always makes the tooth weaker, and we always have to balance the cost of the amount of the dentin that we remove versus the benefits of attempting to retreat any case, either surgically or non-surgically. Is there a right or wrong? Each case must be judged on its own merit. There's no hard and fast answer. The decision of how we retreat cases like this must be considered carefully. How strategic is the tooth in the overall treatment plan? What's the patient's attitude toward retreatment of the case? How understanding will the patient be if the area doesn't respond or if the case requires subsequent surgery or extraction? The ultimate question that must be answered is, does this mode of treatment make the patient better or worse off? It's important that all parties involved in treating the case understand the relative risks, rewards, and obligations prior to initiating retreatment. The referring dentist needs to determine the relative value of the tooth in the overall treatment plan. The endodontist needs to take direction from the referring dentist and the patient so that everybody understands the consequences of undertaking a retreatment. In my practice, I've seen both scenarios and I've treated both of them with good success. CBCT imaging has allowed us to be much more precise when it comes to diagnosing case failures and what the origin of these failures may be. For example, in the case of a radiolucent finding associated with the mesiobuccal root of a maxillary molar, we will always suspect a separate missed MB2. Before 3D imaging, we could only guess. Now we can frequently recognize the missed anatomy on a CBCT scan. The untreated canal can be fairly easily identified, accessed, and treated without too much trouble. This leads us to another decision, whether to treat both canals in a particular root. We know that there are frequent interconnections and anastomoses between canals in the canal system. For that reason, many endodontists will retreat the entire root, both MB1 and MB2, if they suspect this is the case. In a situation where canals have been poorly shaped, or the endodontic fillings appear to lack density or have voids, clearly retreat of the entire case is indicated, especially in cases where these canals are associated with periapical radiolucent findings or a symptomatic tooth. As with any retreatment scenario, we must always consider the importance of the tooth in the overall treatment plan and whether other options, such as surgical treatment to prevent disassembly or extraction or implant replacement, may offer a better alternative for the patient. Remember, when we do the right thing, we both get better, patients and clinicians. Thanks for joining me on this trip. Remember to subscribe. It's free. And I hope you can join me the next time when we go beyond the terminus.